Hello everyone, hello from Spain. I'm Diana Bravo, Product and Marketing Manager of Visionix Iberia. I would like to welcome you to a new Visionix Academy webinar, this time dedicated to the OCT for scleral lenses. It's a great pleasure to introduce Juan Bolivar. Thank you very much for accepting our invitation. Juan is an optometrist graduated from the University of Granada and expert in advanced clinical optometry from the European University of Madrid. In addition, he is fellow of the European Academy of Orthokeratology and Myopic Control. He is also a regular speaker at the Vision by Design Congress, the annual meeting of the American Academy of Orthokeratology and Myopia Control. Currently, his work is very focused on advanced contact lenses and especially in the control of myopia, combining his work in his center with the university. After the webinar, you will receive the recorded session with a link where you will be able to send us your questions and comments. Now is your turn, Juan. I hope you enjoy this webinar.
Okay. Thank you very much to Visionix for inviting me to talk about a subject that I love, OCT applied for scleral lens. My name is Juan Bolivar. I'm from Spain, from the south of Spain, this village where I have my own office and where I work normally. These are some of the most important collaboration that I have. I am involved in this association like AEXO, Spanish Association of Contactology and Ocular Surface. EuroK is the European Academy of Orthokeratology and Myopia Control. Universidad de Granada, where I am external professor of the subject of contactology in pathological cornea. Basically, talk about the scleral lens in different corneal disease. And most of my time, I work in my office where I receive patients referred from all Andalusia for complex cases in ortho-K or scleral lens. During this talk, I will talk about these 3 points. Some application of OCT anterior segment, tips for scleral lenses with Optovue iVue, and what's new at Optovue Solix. We start. The first question, are all OCTs the same for the anterior segment? My answer is no, absolutely no. Normally, for the majority of companies, the anterior segment is the one that is largely forgotten within the OCTs. The development of this part is usually secondary. I use OCT since 2015, and at that moment, when I am looking for my OCT, after a lot of searching, I found Optovue iVue and allowed me to see the previous segment in a fantastic way. There are 2 main types. OCT that give us 5-6 millimeters. These images are from iVue with high quality. The definition is fantastic and even allowed to see perfectly the epithelium. And this was the main reason why I bought iVue. And the new developments allow today to achieve 18 millimeters is amazing. This is fantastic how we can use this size because we could check the scleral lens from one side to other side in the same shape, the entire contact lens in the same image. And the most important thing, maintaining high resolution in details like epithelium. It's amazing. But there are small problems. The cost is high, obviously. But I will talk about Optovue iVue. And the next question is this one worth it? This is mine. And I have using it for 10 years, and it is still essential on my daily work. I use it for posterior segment. It's very useful to detect problems in retina or optical nerve and refer, when would be necessary, to the ophthalmologist. But in my practice, like a specialist in contactology, I love the information that iVue give me for anterior segment. I normally do both anterior and posterior because I want to know from where is the problem of my patient. But I know that if the problem is from cornea, probably I will have possibilities to improve the visual acuity of my patient using contact lenses. Take into account that during this talk, all the images that I will show you are from my office in Alcalá Real and are doing with this OCT. And now I'll begin to explain some of the application that this OCT have. Here you can see the corneal pachymetry maps. Give me the corneal pachymetry of the central 6 millimeters. You can see small details like the location of the thinnest point, in this case very down away from the center because it's a incipient pellucid marginal degeneration. Here you can see the data about how thin is the thinnest point. We have information about the differences between superior to inferior to detect other problems like keratoconus, for example. Here you can see another case more advanced. In this case, you can see different color due to the thinnest cornea the thinner cornea that we have if we compare it with anterior one. You have the location of the thinnest point, and thinnest point in this case is 390 microns. Another fantastic application are epithelial maps. For me, like a specialist in orthokeratology, it's very interesting. It's very interesting because we can have the thicker, how change the epithelial thickness after ortho K. Here you can see a case after ortho K, how the epithelial thickness in the center is thinner, and around in the mid periphery is slightly thicker. This information is very interesting to know if we can have the possibility to push more or not. And we have the option to compare the previous and the next epithelial maps. This is a complex case for a patient who had post-LASIK cornea for myopia. He removed myopia, and this is the typical epithelial maps after post-LASIK for myopia. Normally is thicker in the central area. He had more myopia after the surgery, and I did ortho K. I diminished the measurement of the epithelial thickness only 7 micron, but we have the information how thick is in this part, and with this information I know if I can or not push more in the center or pressure more in the center without staining. This is very good information and very useful information. Another images that we can have is, this is a case with high astigmatism in ortho K. We can use a caliper to do the measurement where we want, and we can do different measure. This case show how different is the changes that we can have in the epithelial thickness in the same cornea. This is the steep meridian where I removed 5.75 diopters of myopia, and how increase the thickness in the mid periphery in the over the ring the red ring area. Same eye, flat meridian, we need to remove only 1.25, and we only increase a little on the mid periphery. We can see perfectly how the epithelial thickness change when we use an adequate ortho K lens. I have a great memory when I presented images like this for the first time. It was in 2015 during my fellow in EuroK conference in Budapest. It was impressive to hear the murmur of everyone in the room when I showed these images or images like this, not in this case, but it was amazing. And nowadays are totally live because 10 years after continue with fantastic precision. But today we want to talk about the scleral lens, and it could be better to talk about a keratoconus. This application is fantastic to detect earlier the keratoconus in a patient. Normally, optometrists only have info about the external shape of the cornea because normally we use Placido topographers, but nothing about the internal shape. However, if we use this epithelial thickness map, we could have an extra info because when keratoconus start, the stroma change from the internal part and steepen the stroma shape. But in early stages, what happened? That the epithelium changed its thickness to compensate the stroma changes. And this is why in early stages the Placido topographies are normal, but they don't show any signal of keratoconus because the epithelium compensates the changes in stroma. This is a case, for example, of grade 1 keratoconus and a small keratoconus. However, you can see here big changes on the epithelial thickness and clear changes. Here are the topographies of this patient. Look at the value. The value is 7.91 millimeters decay radius and 7.45 is a very flat cornea if we are thinking in a keratoconus. However, the topography shows a small keratoconus, very small. This is from a patient who came to my office with visual acuity 20/20 in glasses, came to my office looking for ortho-K treatment, but after the examination, I fit scleral lens to the keratoconus. This is the epithelial maps or the pachymetry maps for this patient on the right and the left for the anterior topographies. And the accuracy and quality of the epithelial maps in iVue is fantastic. The device reads perfectly the separation between layers and give us maps without artifacts. Be careful, especially if the index have good quality. Take into account. This is another level. Solix give us the possibility to know all this data of the 10 millimeters. That is, we can have the knowledge of the pachymetry of the periphery of the cornea. It's fantastic for disease like marginal degeneration of pterium or extreme pellucid. It's fantastic, but as I say before, the cost is high. You can see here another images from Solix where you can see the pachymetry maps, stroma maps, and the epithelial maps. These maps have small artifacts because the shop have a contact lens on. This is why it's too thick. But another application fantastic with iVue is the ball map. The ball map is an application that gives us the separation between the cornea and the internal part of the lens directly. We can have the map of the separation in the 6 millimeters. That is very useful to know what need to do, what parameter we need to change, or if we could have touch in any place of the lens. Another important point is that the precision is very high. The precision of this measure is real because after of each measure, the device asks me for the contact length refraction index, and you need to take into account that if we don't use the refraction index of the lens, the measure is not real. And this is an important detail that most OCTs don't have. But we need to take care when we make the shot, when we push, we need to scan the lens completely. In this case, the anterior part of the contact lens is not on the screen, and that causes that we don't have information. We need to have the entire cornea, the separation between both, and the total thickness, the total lens on the image to achieve this separation. Another application of iVue. This application is using the cornea angle option. I have other device to measure the meniscus, the tear meniscus, but I prefer use the cornea angles with my OCT because the measurement for me is better. Why? Because it's non-invasive, and that's helped to avoid the reflex tear that sometimes have my patient when I use other devices. It's a fantastic tool. We advance with the next point. OCT, is it worth it for scleral lens? Sometimes we have controversy when I talk with some colleagues because some of them say, no, I prefer scleral topographer. Scleral topographer is better than OCT. Really, OCT versus scleral topographers, it's a fight. No, OCT does not replace it. The scleral topographer helps a lot to design the first lens because it reads the surface of the scleral conjunctiva, and this is very useful information, obviously. Otherwise, OCT doesn't do this, but it helps if you have a trial set and a lot of experience. For example, I design my lenses using my OCT with trial lens on the cornea. When I have the lens on the cornea, I make different shots with my OCT and I analyze what parameters I need to change and give me a very valuable information. However, for me, the difference is that OCT allows a fantastic following with the lens on, not only for the fitting, for the future. You can analyze if you need to change parameters for an hypothetical second lens, for example. And the most important, help to me to know how much it needs to be changed. In my opinion, it is not essential in almost anything. That is, everything we see with OCT can be done or seen with other devices, slip down, for example. But OCT confers precision, accuracy, and speed. Implements and completes the rest of the analysis very well. That means that for me, the controversy is not necessary. It's not OCT versus scleral topographer or versus strip down. The information that OCT give me, we can add to the other information. It's an extra info, and the best option is to have all the information as possible. But if some people say me, Juan, is essential OCT to fit the scleral lens? For me, the answer is no, but help a lot. Totally. Help a lot. Totally. The only essential device for me for fit scleral lens is the slit lamp. Slit lamp is essential, but OCT or scleral topographer give us a lot of information. But each one give us different information or help in a different way. The scleral topographer help a lot to know which type of scleral conjunctiva you have in front of you, and helped a lot to decide the first lens. But then OCT, we have with OCT a lot of information during the fitting, after the fitting, and in the next following. And even for decide the lens, we can have the option, as I say, using the lens on the cornea, using the OCT, and give you the information about how much need to change the parameters, and where do you need to change some parameters. Okay, we continue with the next one. Tips for scleral fitting in my practice with OCT iVue. Okay, I explain some details that I normally do in my practice, in my daily practice. We gain precision using OCT when I use the trial set. This is an example, normal example, that for a patient that came to my office, I do some test, and I put the first lens from my trial set. And when I put my first lens, I send directly to the OCT. I check how much is the bolt. In this case, the bolt is 600 microns, and directly I change the lens of the trial set to for another one with 300 less sagittal height micron. See, 300 less micron of sagittal height. Okay, and directly I send to my patient to the waiting room for 15 minutes. After 15 minutes, I do again the OCT, and I'm sure that I will have 300 micron less do the second lens that I choose from the trial set, and a small less do the settlement that the lens have in these 15 minutes. Okay, but I have less time, less shared time, because I'm sure that the separation is the accuracy of the separation in the ball give me the information that I need to choose the second lens totally right. And when I have this lens of my patient, I will check how is the optic zone where the lens is settled. And with OCT, we can see perfectly indentation, like in this case. And the indentation, if you look at this line, is the lines where the sclera is. And this is the line where the lens landing on the sclera. And when these lines are not parallel, we sometimes find indentation, like in this case, where the lens pressed a lot on that area. We can see here the conjunctiva causing a prolapse, conjunctival prolapse. This is not important thing, but sometimes we can see. This is another application. We can see perfectly, and from another point of view, a prolapse, a conjunctival prolapse. We can do this type of measure in order to know how much need to change the parameters for the second lens. It's amazing how we can use the OCT caliper to know how much we need to change. But remember that OCT does not replace slit lamp, and I will show you an curiosity. Okay, here you can see this vessel with the lens on, and sometimes we can see, like in this case, how the red blood cells pass when the lens push a lot over the conjunctiva. It's a curiosity. You can see perfectly the red blood cells. It's very frequent, and if you're looking for this, it's very frequent when you have excessive pressure. Another Another images of indentation, in this case, are from over pingueculas. In Spain, at least, it's very frequent to have pingueculas, and we have a problem when we have pingueculas if we don't do nothing, because the pingueculas after time cause that the patient feel hurt or discomfort or even increase the fogging. OCT helped me a lot to build a microvolve because we can have this measurement, and we have the information on how deep we need to build the microvolve. If I know how deep is the most important measure to build a microvolve and helped a lot. And for beginners, what is a microvolve? Microvolve is an option. We can do a notch too, but microvolve is an option to change the edge of the lens when we have pingueculas or something that I need to solve. Okay, this is a case with the microvolve. We can solve this case. In this image, you can see perfectly how the lens is touching a lot and pressure a lot at this area. And here you can see the shadow that means that the lens is separate due to the excessive elevation that this area have. When we use a lens with microvolve, the edge of the lens fit perfectly to all these parts, causing that the distribution of the pressure improve and don't allow that the debris entry for this part near to the pinguecula that normally are separate if we don't use this type of techniques. Next application, we continue. OCT allows to better understanding of which type of problem we have in front of us. This is a case with advanced keratoconus with central leucoma, very big leucoma. This white area is the leucoma. Okay, we can see the leucoma on the OCT more white than the other part of the cornea. We can see here another case with herpetic scare. You can see how deep is this scare. In this part, the scare is from the middle to the stroma. However, in this part, the scare advances to the internal part of the stroma. It's an extra info that we have with the OCT. Another case, this intraestromal ring is very useful to see how deep is the ring, or remember, as I said before, how the epithelial thickness and epithelium compensate all the changes that we have in the stroma. Here you can see perfectly this image. Another application is we could have fantastic precision in small details, like in this case, where a patient had or show a problem on the top of the cornea. And when I did the OCT, we can see perfectly the separation between these layers. This separation is not possible to see in all the OCTs. The precision that iVue have is fantastic for anterior segment. And this precision gives us very valuable information in compromises areas like this. This is a patient who came to my office after 10 hours with the contact lens on, and OCT allowed to me to see that the lens is so near to the cornea but don't touch. Sometimes before use the OCT, I remove the lens, put fluorescein, and put the lens again. But if I do this, it's possibly that after remove the lens and put the lens again, the separation between cornea and lens will be bigger, will be large. And that is not the real situation. OCT gives me the option to see the real situation. I prefer to use this type of colors in my OCT, but we have the possibility to use this type of colors. I prefer grayscale, but you have this option too. And another fantastic point for me is that iVue give me the possibility to see my patient directly, have the live view. Live view is because we have the option here to, while I am checking my patient, I move the joystick to the left or to the right, and when I see something that is interesting for me, we can do a shot and see the image and obtain the image that I want. Sorry for the bad quality of this image because it's recording with using the mobile on the screen. But it's fantastic, the live view, because you can check all the area moving the joystick and looking for the point that you like it to do the scan. This is a case, for example, of very advanced pellucid macular degeneration. You can see here the patient that came to my office, and we put fluorescein, and we have touched the slit lamp give me fantastic information. You can see here, but OCT give me more information. I'm sure using the OCT, I feel comfortable. This case have more than 20 diopters of astigmatism, 58 for 38. And another detail, you can see here these lines on the down part of this patient cornea, and OCT give me, what is this? You can see here the line is on the endothelium, and give me the information where is this line and what is this line. But remember that OCT is fantastic, but please use the skill of the slit lamp. Don't forget to improve your skill with the slit lamp, because if you use a slit lamp very good, you will have a lot of valuable information if you don't have the possibility to buy an OCT. It's not the same, but helps a lot. OCT give us a better valorization of how the lens settles over the delicate area. I like to see the areas that is delicate, like in this case, for example. If we are talking about delicate areas, we need to talk about the limbal area. Limbal area, as you know, is the area where we don't want to press a lot, because it's the area where the limbus, with the epithelial cells born. And when we have patients with problems, special problem like this, with complicated cornea like this is a terrain marginal degeneration. And I received the patient after time. I put fluorescein on the cornea. I see some details, but I can see especially if the lens over the limbus is touching or not. If I remove the lens for put the fluorescein inside, as I say before, we can have false information, because when I remove the lens and put fluorescein, we don't have the real information, because the lens, it will be with less settlement. OCT give me a fantastic info of how the lens is settled over this area. In this case, the lens landing softly on this area where is fantastic for me. For beginners, this is a schematic image of scleral lens, and the definition of the scleral lens say that the scleral lens is the lens that only touch on the sclera with this part of the lens. Don't touch in the limbal curve or any curve over the lens. Only touch on the sclera with the landing zone. Don't need to touch at any part of the lens. We can use tools like this one that allow to do the measurement to measure some angles. When we fit the scleral lenses, we need to take care with this angle to avoid excessive pressure. If the lens landing softly, like in this case, the lens is landing softly, the distribution of the pressure is similar in all these lines, from the limbus to the edge of the lens. And this is fantastic. But now I will talk about the Hill's effect. On the left, I show you a small indentation on the edge, and if I flatten the edge, I will change the distribution of the pressure, increasing the pressure on this area. And if I flatten the edge more than necessary, I will have excessive pressure here in this area and could cause the Hill effect. What is the Hill effect? This. And could cause blanching on that area or sometimes even hurt. On the right, another case with very high sagittal. The lens is touching on this area, okay, and sometimes could cause a small staining ring, typically from this type of fitting. To solve this problem, I like to increase the diameters, but sometimes it's not possible by the limitation of the design that we could use. And if we decide to increase the bolt in limbal curve like this, we need to take into account that we will have more pressure on that point, and we will have the Hill effect in the moment that we decide to flatten the edge. Be careful with this, because we could cause excessive pressure at that point, and sometimes Hill effect could cause an inflammatory reaction like red eye or hurt, as I said before. This is another image where you can see this part with more pressure. Okay, continue. Another application is OCT gives me the possibility to see perfectly how is the design of the lens, how is the edge of the lens, different type of landing, give me a values information of the different type of lenses that we can have. And sometimes this is a case that I had problems because patient after 3-4 hours came to my office and he said me, Juan, I have a lot of discomfort. I remove the lens, I see a small staining on the edge. When I use my OCT, I saw lack of polishing on the edge. I called to the factory and I explained that the factories say that it's not possible, Juan. All lenses have the same process. All the lenses have the same time of polish. But when I send the image to the factory with my OCT, they don't answer. They directly make another lens. Made another lens. Another application, OCT, give me the possibility to see perfectly the fogging. This is a patient with the lens after 15 minutes, and then the same patient after 6 hours. You can see how the bulb is different, less after time, it's normal, but you can see how patient have more fogging. And when I ask to the patient, they refer like fog, that the visual acuity decrease, the quality of the vision decrease. He see the lights with something around the lights. This is another application that we can use with the OCT. Here you can see a very a fogging with very high density. The quality of this patient obviously is the quality of vision is worse. Fogging is another problem that we need to solve in all of patients. And is it possible to improve? But we talk another day about it. But with OCT, we need to take into account some details. In this case, this is normal, is causing when infrared light passes through the lens. You need to take into account that this is normal due to the different refraction index of the lens. We have some limitation when doing vertical cuts. Not all is fantastic in OCT. Be careful when we do the downed cuts, because to achieve a good quality image, we almost always have to tell to the patient to look at, and the lens usually fall, revealing a larger board than the real one, and sometimes even a false indentation due to the movement to down of the lens. We need to take care about this. Some patient with good eyelids on the right, some patient with good eyelids opening, it is possible to obtain a good image and real image, okay, of the upper part of the landing zone. But in the next slide, I will show you some problems with some patient. Sometimes it's difficult to get a good shot. We have to tell to the patient to look down, because on the left, the patient is looked in primary position, and eyelids and other details don't allow to achieve a good quality in the index, and the image is not so good. I need to say to the patient to look down, and the problem is that the patient, when the patient look down, the lens move up, and in this both images we can see that the lens is not in the same place. Look at this, please. If you look at this, the separation is because the lens is moved to up, okay? Because if we check the initial image, we can see that the lens is over this part when we are in primary position. We need to take care about this. But it's very useful when we use corneal scleral lens, because some of corneal scleral lenses have very small boards, and with OCT we can see perfectly if there are touch or not, like in this case that the board is minimum. Sometimes we have patients that need to add external cylinder to complete the prescription with the scleral lens. We can use prismatic lenses. Here you can see from the top very thin to the down part very thick, how the design change the position of the lens and rotate to the lower position this thicker area. This is another case, very beautiful case for external torus in a patient who need a spherical scleral lens. The stabilization in this case are doing by the different thickness in the meridians. if you look at here and here are thicker on the nasal and temporal, and the top and down is thinner. With this difference of thickness, when patient blinks, the lens rotates to the to looking for the thickest area on nasal and temporal. It's easy to see the difference in the thickness. But normally, for an external cylinder, if the active are toric, most of my scleral lens have the toricity in the optics. Nothing of these are needed due to the rotational stability that the toricity give us. In summary, Optovue iVue is a fantastic tool for optometrists who want to push their fitting to improve and to have under control all the details that we want to know. But Optovue Solix is a device that improves all the tools that iVue give us, and is a fantastic option. And we are talking about the news that we have with Solix. Solix now offer the possibility to use a topography module that complete the information, because we don't have nothing about the internal the posterior part of the cornea. And with this module of the OCT, we complete this information. We will have information about the anterior and posterior part of the cornea, obviously pachymetry, obviously all the option of the topographies, and it's very useful. Even we will have very complete information about aberrometry, because we will have the aberrometry from the front surface and the posterior surface. We can have the possibility to customize the report that we have. We can choose which maps we want for all reports. And another small detail that I like a lot is the pachymetry trend analysis. If we are thinking on keratoconus patient, we can see if the cornea is changing to thinner or not, and how change in each part of the 10, remember 10 millimeters is fantastic. Not only for keratoconus, for all the corneal disease. In summary, Optovue iVue is fantastic. Optovue Solix is another level. Probably is my next level, because it's a level. It's fantastic for optometrists who want to have the latest technology and apply the latest technology to their the daily practice. But if you don't have the possibility to obtain Solix, iVue give you a lot of information. Anyway, don't forget the next. Buying OCT doesn't mean that you are good at fitting a scleral. Really, the knowledge gives you the chance to improve. But an adequate OCT facilitates it. Thank you very much. Thanks to Visionics. I hope that you enjoyed this presentation. I hear your question. Thank you very much.
Thank you very much, Juan, for this fantastic webinar. It has been really interesting to learn more about all the not so well-known application of OCT in contact lenses and anterior segment. Thank you all for your participation. Through the link, you will receive the recording of the webinar. You can send us your questions and comments. See you in the next edition of Visiones Academy. Stay tuned.